Thank you very much for the invitation. I'd like to thank the Professor Spargias, Dr. Patakos, and all the friends of the organizing committee for the kind invitation. And we will see a case that we did a couple of years ago, and it's a patient that is of high risk for, thank you, for occlusion of the left main. And we will see how we can, sometimes we can be misled by the evidence that we have from the echo and from the coronary, from the catheterization. So let's see our case. She's an 87-year-old female with severe aortic valve stenosis, good ejection fraction preserved, a Vmax of 4.5 and an area of 0.62. She was on NIHA Heart Association, New York Heart Association 3 to 4, and she had a permanent implantation of a permanent pacemaker DR a couple of years before the procedure. In the coronary catheterization, she had no significant coronary artery disease. She was deferred for SAVR, and of course, she was planned for transfemoral TAVI. These are some facts from the CT scan that we had. As you can see, we had the two major concerns. The first one was the high of the coronary ostium, especially on the left main, which is 7.9, and the right ostium is much better, and the small diameter of the sinus suprasabra, which was below 28. So we knew that this patient was high risk for coronary, for occlusion of the left main, so we decided to go with an Evolute R with a 26 millimeter, and we intended to go with a very deep implantation. We knew exactly that the skirt of the depth of the length of the skirt is about 13 millimeters, so we intended to go with a depth from the annulus of about 7 millimeters, so that the remaining 6 millimeters would be enough not to have occlusion of the left main. In this case, we had two major concerns. The first one was that we were not afraid of the possibility for a pacemaker because the patient had already a pacemaker, but we had to go with the oversizing because we didn't want to leave any significant PVL in this patient. So this was our setup. As you can see, we went with left femoral 6 French Judkins 4 guide, with the right radial with the 5 French pigtail. This is a setup that we use especially with the pigtail, so we think that it's much safer and not to have complications from the femorals. And we decided to go also with the chimney technique, so we parked the 4.0 stent in the mid-LAD, hopefully, and we didn't intend to use it. This is you can see on the left panel that we have already the first aortography and the amplats in the left ventricle. And you can see also we passed the confida, and this is the first valve that we did with a small balloon, 16 millimeters balloon, and we see the aortography. On the right panel, you can see that it seems that we have a massive AR, regurgitation of the aortic valve, and there is not a very good visualization of the left main during that time. The problem was getting much worse because the patient was hypotensive. We thought that she had the left main occlusion, and she lost consciousness. We started to go CPR and intubation, and of course, we inflated the stent in the left main, and all of the others continued. However, nothing changed. The patient was getting worse. You can see that we had a lot of good CPR because we were able finally to keep the patient alive. But however, we couldn't have any ROSC, return of spontaneous circulation in these patients. So probably what we did was not enough. And finally, after a couple of minutes, we used the echo, and we saw that the problem was not the occlusion of the left main, was this effusion of the pericardium that we drained. And as you can see, the final result was quite good. The patient survived and was extubated after 2 days. She was in the clinic after 4 days. She had a coronary COVID infection, and during our last checkup, she was planned to go for some other minor operations, and she wondering whether she could stop the antiplatelet therapy. Thank you very much.
Wonderful case, Andreas. So what do you think was the reason for the effusion? Or do you feel it's
most probably was, if you could see, during the second or third slide, the balloon was moving towards the apex of the LV. So most probably, although it was a small balloon, 16mm balloon, that was the reason what caused the rupture.
You didn't push the wire.
Yeah.
Any comments from our moderators here? Dr. Avlira?
Congratulations, Andreas. As far as I understood, the annulus was not so calcified. Did you consider to go straight with a valve and to avoid the balloon, the predilatation with the balloon?
Okay, it had some calcification. However, we wanted to see also how it will be the calcified just after the balloon, because it would be a good chance to see how it will behave, the whole valve. However, it was an option. The calcification was not quite high, so we could go directly. But usually, it's when you go for the left main, you try to have a strategy to see whether the behavior of the native valves could be, or the calcium will be good or not appropriate.
Congratulations, Andrea. Excellent case. To pinpoint that there are many things that could go wrong, and not only our automatisms. It's not our automatic thoughts. So it was different. It might be from the massive regurgitation. It might be from the coronaries, but it was from the pericardium. Should you have done this procedure more recently? Would you prefer some other materials or another valve or another procedure?
Well, this was what I was thinking about. During that time, what we were thinking at the common knowledge is that usually you need a short valve, a balloon expandable valve. That would be much safer in this case. However, as you know much better than me, probably, there are some case reports and some case series that show that these valves, the self-expandable valves, they can go much better and they have less percentages with occlusion. Most probably, this is because of the concave part of the mid part of this valve that does not exist in the balloon expandable valves. So I am not sure whether we would go with a different strategy. The wire, I think, was the confident was a hypertrophic ventricle. I think we would go with the same. I think what we will do, most probably, we wouldn't be so easily misled by the fact that we were afraid that the most possible cause would be the occlusion of the left main. So we would avoid the implantation of the stent.
All right. Thank you, Andreas. Thank you very much for the case. I would like to call up Dr. Lampropoulos from Euroclinic.